Yeah, brilliant, guys. So this is Chris Llewellyn. It's a former colleague of mine. He works at the Aberdeen Royal Infirmary in Scotland, and he's a really nice guy. He's really, his specialty is actually in EP and devices. He's really good guy. So I train under him. So he's just coming off a chest infection at the moment. So he might be coughing halfway through, so just excuse him for that. He's also on call, so if he gets called and gets interrupted, then AJ will take over with the quizzes, and that's so. Thank you so much, Chris, for coming to do this. So over to you, Chris.
Okay, so I'm going to talk about this. This is a bit of an old talk. Julius asked me at the last minute, so I've just pulled something that I already had. He asked me to talk about implantable loop recorders, but you can't really talk about them without talking about how they fit into the Syncope guidelines as a whole. And so I'm going to just talk about it's mostly the 2018 update to the Syncope guidelines, but it's a lot about how we've worked it into our service in Aberdeen. So what I'll do is I'll just start. Oh, I need to be made host to start sharing. Julius?
Yeah, it looks like you're still
Done, Chris. Done.
I need to be, yeah.
Yeah, I've made you a host.
Okay, let's see.
And then if you have questions in the chat, just post them. And then when there's a good time to stop, we can ask. So feel free to write in the chat.
Right. So my name is Chris Llewellyn. I'm a chief cardiac physiologist at Aberdeen Royal Infirmary. My main interests are in clinical electrophysiology and cardiac devices, but I have got a bit of an interest in syncope, and given that I do quite a lot of the syncope testing, tilt tables and implantable loop recorders, and a lot bit of monitor analysis. So quickly, you kind of have to define syncope before you start, which is a transient loss of consciousness due to cerebral hypoperfusion, characterized by rapid onset, short duration, and spontaneous complete recovery. Transient loss of consciousness is defined as a state of real or apparent loss of consciousness with loss of awareness, characterized by amnesia for the period of unconsciousness, abnormal motor control, loss of responsiveness, and short duration. So they're generally classified into a few different main groups. Reflex, which is the vasovagals, orthostatic, vasovagal, emotional or fear, some sight of blood, situational, micronician, coughing, sneezing. And in fact, we just had presented a case in Portugal of a very interesting swallow syncope, and we're about to do some more testing on that patient. Carotid sinus syndromes, and then some other non-classical forms. Syncope due to orthostatic hypertension, that's either drug-induced, vasodilators, diuretics, volume depletion, primary autonomic failure for neurogenic type things, and then secondary autonomic failure, things like diabetes, spinal cord injuries, things like that, which affect the autonomic system. And then cardiac syncope, which is quite often my main area. Arrhythmia is primary cause, so either bradycardia, tachycardia, either supraventricular or ventricular, although it's very rare for SVTs normally to cause actual syncope. And then structural, for example, aortic stenosis, MI, ischemic, cardiomyopathies, masses, tamponade, things like this. And then cardiopulmonary, so pulmonary MLI, aortic dissection, all these other things. So this is a diagram from the ESC guidelines, which give you an idea of how you get cardiac syncopes, and syncope in general can be of multiple different causes, either low cardiac output or low peripheral resistance. And these things interact, and they never you quite often see kind of syncope that doesn't really fall into a single box. Sometimes there's more than one thing going on, or it's mixed responses, and that's fairly common. So when a patient presents with syncope, the most important thing is history taking. And I'll go into a little bit about some of the scoring systems, major and minor criteria for risk factors. But if you have transient loss of consciousness, non-syncopal, treat appropriately. The bit we're interested in is this middle part, this syncope part here, which is do a little bit of initial syncope exam, ECG, blood pressures, supine and standing. Given the history, you sometimes get a bit of an idea about what it's likely to be. If it's low risk and rare, explanation, you don't need to do much further evaluation. Low risk but recurrent, sometimes you need to do some other tests just to reassure the patient. And we'll go into some of the tests that we can do after this. And then if you see high risk or short-term episodes, serious events, then we really need to start doing early evaluation and treatment. If you've got a certain highly likely diagnosis, then you should start treatment. In fact, the problem with a lot of the syncope that I see is, although it sounds highly likely, we don't really have particularly great treatment, especially within the TELT patients that I see. So history and examination. So if you see, there are a number of factors which are either low risk or high risk. So certainly patients with a high risk need to be treated slightly differently from those with a very low risk history, low risk examinations. So the main high risk ones that I find are certainly with syncopal events, sudden onset, certainly during exercise or when sitting, resting, and certainly syncope with injury seems to be probably one of the highest risk systems that we see, and that's what most of my loop recorder implants are for this. Although you get all these scoring systems, none of the scoring systems, when you actually look at it, do any better than physician assessment for physicians who see a reasonable number of syncope patients every year. So people tend to get you tend to get a feeling about it. Scoring systems don't do any better than a reasonably experienced doctor. So when you do have a syncopal episode, if it's low risk features only, likely reflex situational or orthostatic, can be discharged, and most of what you can do for them is patient education, and certainly we do a lot of patient education for this. If it's neither low nor high risks, then patient can be discharged, but maybe you should start to think about some other syncope investigations. Unfortunately, within our hospital, we don't really have a true syncope service. This seems to be split amongst multiple services between general practitioner, the acute medical assessment unit, and cardiology. So there's quite a number of places see them. The tests all tend to get referred to cardiology for evaluation, but the vast majority of the patients are seen not within the cardiology service. And then if you've got high risk features, then maybe the patient should not be discharged until they've been evaluated for this. And certainly you want to get treatment, admission for treatment, diagnosis or treatment. Sometimes they have high risk symptoms. These are the patients that we tend, you really want to sort out as to whether or not you need to do further investigations, something like long-term monitoring, or whether or not you want to start a treatment if you've got a likely cause. So the diagnostic testing that can be done, and I'll go through a few of these bits of this. Carotid sinus massage, active standing. We've started introducing, I see we need to introduce this, was based on our old service. We have introduced a bit of active standing testing. TELT testing we do quite a lot of. Basic autonomic function testing. There is relatively weak evidence for using this in the syncope service. Some parts of it are stronger than others. 24-hour Holter and ambulatory monitoring and blood pressure monitoring. There's mixed, it depends on what the symptoms are, whether or not these are of any use. In hospital monitoring, again, you're probably better getting onto a proper form, the most appropriate form of monitoring for the patient. Holter monitoring, prospective event recorders. We see a lot of patients nowadays coming in with smartphone applications, smartwatch applications, and we are suddenly expected to, GPs are emailing us in hundreds of these bits of recordings that patients have given them, wanting to have an opinion on it. This has become quite a burden on our time because the vast majority of the recordings that we get are either uninterpretable or perfectly normal. So there's a lot of companies starting to offer a lot more things which are remote in-home telemetry. Most of these systems are actually quite expensive, although they're quite expensive per patient. Implantable loop recorders, we do quite a lot of these, and I think this is probably an area which I think we need to expand in. We seem to be missing quite a lot of patients in our service, certainly, that we should go directly to implantable loop recorder. It is expensive, but it works out good value if you don't actually do a lot of the other tests first, if you just skip straight to that sort of step. Now, one thing that we do advise patients to do is video recording of syncopal episodes. Certainly if they have multiple episodes, we ask family members to record them. It's actually very useful to be able to see the recordings. It gives you much more of an idea, and especially patients who've got security cameras or in their homes, these can be quite useful. Electrophysiological studies, we do a bit, actually only about 3% of patients who have syncope with some suspicion of cardiac actually end up having an electrophysiological study, but they can be very useful in diagnosis of cardiac syncope. Adenosine and other biomarker testings, very weak evidence for this as well, and doesn't seem to be particularly useful. Echocardiography is extremely important. Having structurally normal heart does or not changes your management of the patient. Stress echocardiography can be a little bit useful. Exercise testing, just standard exercise testing on treadmill, can be useful, but only if the patient has syncope immediately after, during or after exercise. Coronary angiography can be absolutely necessary in patients who have some suspicion of structural heart disease. So, carotid sinus massage, basically if you can press on the carotid sinus, cause a pause lasting of greater than 3 seconds and a fallen systolic blood pressure of 50 millimeters mercury, is probably carotid sinus hypersensitivity. It's a relatively common finding. Speculative tests increase spontaneous syncope is reproduced during carotid sinus massage. The main complications of doing this are neurological, so TIs or strokes were observed in a tiny percentage, so 0.24%, so very small percentage. Previously, the risks of this were included in the previous set of guidelines, but they've been kind of downgraded a little bit. Active standing testing can be extremely important. So basically, this is a test used to do. It can be useful differentiating different types of orthostatic hyperintolerance. So basically, we use a FiniPress system, which allows us beat-by-beat blood pressure monitoring. Although you're much better using a cuff and a stethoscope if you're going to do it without an automatic monitoring, because you need to make fairly accurate systolic blood pressure measurements on a very quick basis. Automatic arm devices, to repeat, are not in my experience, not particularly useful. They sometimes take a little bit too long to make the measurements and often don't quite work fast enough. The more frequent the reading, the better. And then an abnormal blood pressure fall is a sustained fall of 20 millimeters from baseline, but we would expect a decrease of under 90 millimeters to be really particularly significant. Next area is tilt table testing. Despite the fact that I do quite a lot of tilt table tests, I don't think it's a particularly useful test overall within the realm of it. Often it is just used to confirm what you already suspect. So if you have a history of vasovagal syncope, you're extremely likely to have a positive tilt test, so about 80%. For other tests, for example, for reflex syncopes, or its diagnostic usefulness is about 50%. And it does have a significant false positive rate, somewhere between, we say 8 and 13%, but actually it may be as high as 20%, depending on which protocol you use. And we use a GTN, we use the Italian protocol, which uses GTN at the end of the last 20 minutes of the protocol. And that seems to improve the diagnostic reliability, but also increases the false positive of it. So this basically just gives you an idea of the likelihood of picking up something with it. So typical vasovagal syncope quoted as 92%, but I kind of quote between this 78 and 92%, somewhere around the 80-ish percentage points. Reflex syncope about 50%, cardiac syncope again 50-ish percent, unexplained syncopes down in the 30%, and given that the false positive rate is somewhere in this territory, so between 8 and 13%, it's not particularly useful in unexplained syncope. It's very good at being a confirmatory test to vasovagal syncope. The very important thing that we've learned from this is that taking a very good history is extremely important, because what you want to be sure is that you're reproducing exactly the same symptoms that the patient's had before, and it's not a false positive for some very different symptoms, very different feeling for the patient. So some of the autonomic function tests that we do, Valsalva maneuver, a bit of evidence that BP overshoots can be associated with neurogenic orthostatic hypotension. Deep breathing exercises, again, we don't do a lot of this. There's some evidence, but actually it's not as good as we would like. Other autonomic function tests, cold pressure tests, sustained grand mental stress tests have very limited evidence. So Holter monitoring. Most patients who come into hospital with syncope get a Holter monitor, and we did an internal audit, showed it was less than 0.5% got any result from Holter monitoring for 24 hours in the first, immediately after a syncopal episode. In fact, looking at the published data, that could be as low as 0.2%. Holter monitoring may be inexpensive, but on a per patient basis, but it is very expensive to your health system on cost per diagnosis of syncope, given that you would probably have to do somewhere in the region of 200 to 1,000 tests to pick up one positive result, which is quite a large burden of analysis. Prospective external event recorders, for example, Apple Watch, the little smartphone apps that you can press at the side, or any of the other monitors where you have to stick the event recorder on or press a button, are not much use in syncope because you're not able to make the recording. Most of the smartphone applications fall into this category, although they are getting better and some of them are able to make some more automatic recordings. So there's a big rise in external loop recorders, and this is quite a pricey business for the health system to get into. They've quite a high diagnostic yield, or certainly higher than Holter monitoring. Things like the Zeo patch and some of the other wearables, which is, I've seen some of these starting to float about, which is the wearable biofabrics, can be worn for quite a long period of time without skin irritation. No matter what, you end up with an electrode, some form of electrode attached to the chest, and the device recording for probably about 14 days. The biofabrics will probably make it much easier for long-term recording, especially if it's linked up to smartphone apps. diagnostic yield can be in the 20%, provided you pick the right patient group, and these are patients with episodes which happen more than once a month. So implantable loop recorders, this is shamelessly promoting the Reveal, but we have used more than just Reveal. We've used the Reveal, Biotronics Biomonitor, Abbott's Confirm, and Boston's Lux device. And I think I might just let this play through. So this is a relatively straightforward technique, and in the UK, but certainly Scotland, about 90% of, more than 50% of these are now done by cardiac physiologists. Of the remainder, about 25% are done by nurses, and the rest are done by the medical staff. So it's a relatively straightforward technique that you can teach to quite a large number of people. Well, I have to say, I don't particularly like this, the implantation tool. We use a scalpel ourselves. And the devices are all relatively easy to implant. Dilate underneath the skin, put the device in. I'm going to skip this forward a little bit. Turn the device around and pop the device underneath the skin, leaving the device behind. And then most of these are just closed up with steri strips. Occasionally use a little bit of a stitch. This will just go on for a few days. Relatively straightforward. So implantable loop recorders, I think these are a really useful tool. Prolonged monitoring with the loop recorder results in a 3.7 times increased probability of diagnosis compared to an external loop recorder tilt testing electrophysiology study. They are quite expensive, but if you look at the economic evaluations, if you go straight to implantable loop recorder, it is much more cost effective than throwing lots and lots of tests at a patient and eventually hoping something hits. But I still think they're too expensive and the price needs to come down a bit. So for the indications for loop recorders, class 1, recurrent syncope with unknown origin with high-risk features, recurrent syncope with high-risk features that could that investigation has not revealed the cause of. And there's a class 2 indication for diagnosis of unexplained falls, epilepsy, and reflex syncope. I have to say that we have done quite a lot for epilepsy that has not responded to medication, and we've had a whole bunch of mixed results. We've both seen both seizure activity and asystolic event and a non-sustained VF, and amongst that group. And basically, this is the guide from the syncope guidelines. This is the guidance for implantable loop recorder implant. So early phase evaluation, class 1 indication, patients with high risk criteria, who a comprehensive evaluation did not yield any reasonable cause. Certainly, there's a lot of talk about implantable loop recorders for AF monitoring, but the evidence for that has been very, very mixed. And a lot of the negative studies haven't really published their data fully, but the general feeling from what we've seen is it's not particularly helpful. So, diagnostic criteria. The gold standard is for arrhythmic syncope is when you correlation between symptoms and an ECG recording. And that's often very difficult to do. In the absence of arrhythmia during syncopal episodes, allows the exclusion of the arrhythmia as a mechanism of syncope. The permissible limitation of any ECG monitoring device is the ability to record BP along with the ECG, which would be quite useful. And in reflex syncope, the documentation of bradycardic or asystolic episodes during a syncopal episode does not rule out the possibility of hidden hypertensive reflex as the principal cause. And actually, when you look at a lot of loop recorder or Holter monitors for patients who have hypertensive syncopal episodes, you can kind of get a feel for it. You sort of see this heart rate rise just before it and a tailing off. And I haven't really covered that. So for video recording during syncope, in-hospital video recording, in our hospital, it's currently only used neurology. We've actually started to use it in tilt table testing, largely because we have a single person doing the test, and actually it's quite useful to review the recording, but you can see both the ECG and the patient to see when where and when the syncopal episode happened, and give you a little bit of an idea of it. Just allows you to make a slightly more accurate report. It is useful if anyone has home recorded their syncopal episode, or a relative has recorded a syncopal episode. It's useful for you to be able to see that, because it gives you quite a lot of clues to what's going on. As I talked about electrophysiology studies, actually very few patients who have syncopal episodes get electrophysiology studies. Although we are a reasonably sized electrophysiology centre, we still don't do a lot. We do maybe a handful a year looking for HV block or arrhythmic cause. So it is a very small number of these patients that actually go to electrophysiologist testing. It is expensive. It takes lab time, and it takes a reasonable electrophysiologist to do a reasonable test.
Dr. Llewellyn?
Yeah.
Sorry to interrupt you here. You mentioned the recording for syncope. Could you kind of elaborate on what you're looking for to kind of rule out different things for the group?
So yeah, so what we're interested in is basically things like loss of patient color, seizure activity, especially if you get the onset of the episodes. We're starting to see a few more recordings as we've asked people to, certainly people who have recurrent syncope, we've asked relatives to record. There is quite a lot to be gained from it, I think. Especially if you can catch an onset of an episode. Frequently we only get the middle and end of it, which is not as helpful. And patients who have long asystolic events can have seizure activity, which is as a result of hypoxia rather than an actual seizure. So it's useful to see if it's starting with seizure or whether or not this is a sudden drop attack. And we've seen quite a lot of recordings from our patient. I've seen quite a lot more recordings from our patient in the last few years, and it just gives you a little bit more idea. Also, when you're doing your other testing, for example, if you're doing tilt table testing, it's useful if you've got a fairly similar sort of response as well.
Okay, that's great. Thank you. With your tilt, by the way, you mentioned that. Do you have any kind of safety protocol in place for tilt? Just because I've had anecdotal reports of people have lost a patient in a tilt table test, for example.
The risks of tilt table testing are extremely low. Mm-hmm. It's performed in a hospital environment. We are in a ward area which has it's part of the cardiology ward, so we have access to the cardiac, a full resus team. You don't really ever need it. You tip a patient back, you get them back. That's the bottom line. The relative risks are extremely small, and they're in the 1 in 15 to 20,000 sort of territory for serious risk, and actually most of the serious risks don't involve death. So there's a small risk of MI stroke with any of these tests, but I think the relative risks are absolutely tiny. The problem is it's anecdotal evidence. You just get one bad story and that you remember, and then everyone panics about it. But
no, I appreciate that. Yeah, we had one of the places I worked, that hospital, they put pads on every patient because they had one instance of it, and 20 years ago, and they never forgot.
Yeah, I mean, you can induce arrhythmia. Induction arrhythmia during tilt is rare, but I mean, prolonged bradycardic episodes can do that. I haven't seen it. I've had to start CPR in one patient who didn't come back, and that was a neurogenic syncope, and they basically just had a long asystolic event, and then decided not to come back when we tilted them back. But they did recover fairly quickly. So EP guided therapy, I probably won't go into a lot of detail on this. Certainly prolonged HV interval is prolonged HV interval is a very strong indicator of needing a pacemaker, which is the His to ventricular signal. Certainly inducing of arrhythmias is a very useful tool for suspected ventricular tachycardias. And as I said before, actually SVTs or supraventricular tachycardias are very rare that they cause syncopal episodes unless they're extremely fast. I'm not really going to go over this because actually the evidence for all of this is okay.
Drop it.
Did we have a question from the group? Dr. Llewellyn, you may need to mute that specific participant.
Okay.
Right.
There we go.
Right. Biomarkers. Oh, somebody is drawing on the screen. Biomarkers are not particularly useful. The evidence is really quite weak and don't support use in routine testing. Echo is an extremely useful thing. Certainly a normal echo does reduce the overall risk. Structural heart disease certainly increases the risk. Exercise stress echo, useful in patients with hypertrophic cardiomyopathies that complain of exertional or postural syncope. Exercise testing. Exercise-induced syncope is infrequent, and actually, certainly, yeah, we'd possibly do a treadmill if we suspected it, but there is a degree of risk to this. I've had one patient who had exercise-induced syncope come off the back of the treadmill at about 14 minutes of Bruce, which was not particularly pleasant. It's useful for, it's only really useful if you have syncope during or shortly after exercise. And then this was just a slide basically explaining the updates from the old 2009 guidelines up to 2018, with the this side here being the 2009 guidelines. Basically some contraindications to carotid sinus massage being removed, tilt testing being a main indicator to go into a bit of a grey area sort of territory. Tilt testing for educational purposes, again lowering its evidence level, and tilt diagnostic criteria has been changed a little bit. And then tilt testing for reassessing therapy has just been removed. Holter monitoring for unexplained syncope has been moved from its class 1 indication to a class 2A. I still don't think it's a very useful test. You'd much better with a prolonged monitoring method. Electrophysiology guided pacemaker protocol, not particularly, again, extension of recovery time, not particularly useful. As we've put, the guidelines now point out, for an indication for a pacemaker, there is no patient who should get a pacemaker for a sinus pause unless they have symptoms associated with it. Empiric pacing by ventricular block, again, all these things. And then certainly there's some changes to the management from discharging from the emergency department. Keeping people in hospital unnecessarily for a bit of vasovagal syncope is probably not helpful, and it's certainly for the hospital, the way in the UK the hospital system is at the moment, that we just don't actually have any beds for patients. And there's some interesting bits that have been added in, which are video recordings for spontaneous episodes and implantable loop recorders with epilepsy and unexplained falls, pretty weak evidence for unexplained falls. And basically, actually, we do a lot of this now, which is implantable loop recorders in patients with primary cardiomyopathies or things like ARVC, and some of the congenital patients who we just want a bit of long-term monitoring, who frequently have a cluster of symptoms which may or may not be related to arrhythmia. And that's all. And I will. Sorry, I'm just trying to pass back control to.
Here, let me go ahead and retake control. I'm going to try to clear those annotations out. Sorry about the distraction there.
That's okay. So hopefully that was useful for people. If anyone's got any questions.
Yeah, let's take a look. Anyone in the chat, if you have any questions at all, please feel free to post them. One thing that came to my mind. So what we've started to do for our loop recorder implants is we like to actually map the patient out, especially for larger patients, to try to see where you have the optimal P waves for AFib monitoring or QRS complexes if you're trying to look for like VT, syncope, things like that. Do you do any kind of mapping with an EKG ahead of time, or
no? We found it's certainly looking at the 12 lead and trying to figure out the best vector. We tried it for a while. It seems to make absolutely no difference.
Okay.
Putting some electrodes on roughly where your position is can be useful, but I will never use that. And if I'm going to go for an alternative site implant, so sometimes, for example, certainly for women who are getting breast investigations for suspected cancer, we implant below the breast or around at the side, and we map. What we do is we map the standard position, and as long as it's not less than 2/3 the size, then we'll put it in one of the alternative sites.
Okay, interesting.
But we generally don't really change our position much, and we don't really have a big problem with poor quality signal. We did try mapping for a while, but we've given up on it. You're just as quick just throwing it in. As long as you've got people consistently doing it all of the time, and you're getting it directly below the surface of the skin rather than into fat. I think that's the factor I think that makes more of a difference, is keeping it close to the surface of the skin.
So you found with larger patients that instead of actually trying to go deeper in and get closer, you have a tighter pocket, I assume, if you're just underneath the skin, or?
Yeah, well, no, it's not that. It's the fact that fat does not conduct. And actually what you're doing is you're actually recording from the underside of the skin. It's the same as putting an ECG on from the outside. Think about it that way. You're making a recording on skin, not as soon as you bury part of the device in fat, it's insulated on all sides from any good recording surface.
Interesting. Yeah, I don't think that's been a strategy that's been expressed to me. So that's good to hear, because a lot of times some of the physicians we work with will try to go deeper because they're trying to get through the, that makes sense why we're actually maybe costing ourselves some signal.
Yeah, you really want to keep it as close to the surface. You want to keep it a few millimeters underneath the skin. You're not really wanting to be deep. Okay. And you see, especially if the tail end of the device, shoots off and decides to go a little bit deep, you'll get a poor quality signal.
Okay, interesting. One thing you mentioned, or you showed the video with the link, the reveal.
Yeah.
I will say, just this is for the whole group. I'm obviously Abbott biased, but I would just say make sure you look into the different implant technique for that specific device, because even though there's some universals, there are some best practices that may make your life a little easier. So just for the group, if you're doing a Confirm or down the road Jot or any of those others, the way the Abbott incision tool works, you want to actually pull the skin apart and go through there, or put your finger down and go over the top of your finger to stretch the skin rather than mounding it up. So we had a lot of initial issues with people who were link implanters that would mound the skin and try to stab through it. And because the blade is a different shape, it just doesn't go in as fluidly. So that would be my best advice. I don't really know how to do the Biotronic or Boston monitors, but I will tell you there are some best practices. So always just reach out to your expert on that specific device, and they can talk you through it. And that's just my advice to the group.
I gave up with the implant tool about 5 or 6 implants in, and we just use a scalpel to make the incision.
Scalpel, 11 blade, yeah.
Yeah,
I will tell you the new one with the Jot is much better, but the first one that came out with the Confirm was basically a spoon. So the 11 blade was a lot easier.
I think it just makes a neater cut, I think, and the healing's a little bit better. I think it's certainly we have quite a lot of young patients, certainly young female patients. The cosmetic aspect of it is quite important, which I do suture most of the younger patients just to hold them in together a little bit neater. Quite often steady strips don't quite hold quite well enough in young patients.
Wound care recommendations. Do you have any wound care recommendations for us at all? Post-operative?
So I keep site dry for 5 days. So we put a Tegaderm waterproof dressing. We put a normal just Mepor, steady strips Mepor. We put a Tegaderm waterproof dressing over the top. Keeping it dry for 5 days just reduces your infection risk a little bit. And patients, despite the fact you say you can't wash or get that bit wet, will still want to wash and get that a bit wet. So giving them a little bit of a little bit of dry for a little bit of time does make a big difference. I'm of the opinion that if it looks gapey when you cut, so you use the young people with very stretchy skin, it sort of just pulls apart as soon as you cut. Stitching them, I think, makes a big difference for the cosmetic aspect. And if you make a big difference in the cosmetic aspect, you're also a little bit easier in the healing. But it's just a single interrupted suture right in the middle of the wound, and that's all you really need. Nothing complicated.
Fantastic. We had another question. I don't know. I'm unmuted. Okay, perfect. How long are the loop recorders implanted, and how are they analyzed?
So we use largely reviews. We have used Medtronic reviews. We use the original review. We've not went to Link 2 because we don't think the price point is worth its additional features. We've got experience with the Confirm. We've got experience with Biomonitor 1, 2, and 3, and the Boston Lux. So we've had a fair amount of experience with everything. Most of them are monitored remotely via home monitoring system. Previously, we used to just see these patients in clinic once every 6 months, and then if they phoned in with symptoms. And if you don't have access to the home monitoring systems, it's a reasonable thing to do. Patients will show up if they have symptoms. They will show up in hospital if they have symptoms. You do catch a lot of stuff that you would not expect to catch when you look at the home monitoring systems. And I think they're very valuable. And certainly some of the newer devices that are remote reprogrammable, that's an extremely useful tool as well.
Yeah, and just to answer the question there, how long the batteries last, it really depends on the device. So the Confirm, you're looking like around 2 years with consistent Bluetooth connectivity. It's fairly similar to the Reveal with their Bluetooth fully on, but if you're 3 years, if you don't have it running, lasts longer there.
3 years with the original Link, I think it's a bit less. The Boston device originally said 4, but if you use the Bluetooth, again, it's significantly reduced.
Yeah.
And the biomonitors seem to just last forever.
Yeah.
And biomonitor.
Oh. Sorry, I muted the wrong person there. Dr. Llewellyn, I might have muted you on accident. Let me see if I can find you. Yeah, sorry, I muted you. Do you mind unmuting yourself?
I've done it, yeah.
There we go.
The original biomonitor lasted for about 10 years, which is far too long. We actually don't want to monitor people for that long. It just costs you extra money. And I've used some of the newer biomonitors. They seem to last for an extremely long amount of time. They've not even ran it. The biomonitor 3s that we put in a while ago haven't even come close to running out of battery yet. And they're 4 or 5 years in.
Those aren't technically insertable. Are those almost like a more?
Yeah,
they're a little.
Yeah, they're not pleasant to implant. I'll be honest about that. They're a little bit uncomfortable to implant. It's a much bigger cut, and it's a much harder push.
Yeah. I'm not sure if you saw it. I'm not sure whose device it was, but one thing I would warn to the group, as these are a very simple procedure, I think it's very easy to get comfortable. But just make sure that you're doing these as carefully as possible, just because there has been instances where people have gone too deep and actually split the ribs. I think one of them was actually into the heart, which I'm sure had great, R waves for as long as that lasted. But please be careful, especially with longer devices, putting those in.
Yeah, the big key is implant them flat and keep them close to the surface of the skin. You can't go wrong that way.
Yeah. Perfect. Any other questions from the group at all? Dr. Edafe, do you have anything for us?
AJ, yes. Can I just show what we do in Nigeria here with regards to loop recorders?
Yes,
absolutely, sir.
Presentation. Can I just share maybe 1 or 2 slides?
Yeah, let me give you.
Yeah.
There you go. Okay, there you go.
Good. So let me just show. I hope okay.
We had a question about the Zeo patch and the Medtronic Seek require telemetric reception center. How could we use this in the region? I don't know if someone else can speak to this, but if you can remote interrogate, or if you can in-person interrogate it, then it'll be much easier. Sorry, Dr. Edafe, I'm interrupting your case here.
Yeah, so this is a loop recorder. We plant it a lot here in Nigeria. As Dr. Chris said, we don't have the remote monitor. So what we do is we ask the patient that when there is a symptom, you quickly report immediately. That is the way we use in getting the monitoring done in the absence of a remote monitor. We are working on it. We hope we will get it very soon. Then the other issue is that, as you said, the key things when you do this implant is you have to ensure that the skin is adequately prepared, because the commonest problem with this implant is infection. And once it gets infected, you just have to take out that implant. Since I've been doing them, I've not gotten any infection because I take very aggressive measure to prepare the skin to ensure that you don't have any infection. Then also as Dr. Chris said, is I use an absorbable suture just to close the point of punch. And if you adequately anesthetize along the part of that skin, the anesthetic, because I give the anesthetic under the subcute, so it raises the skin for you. So you take it across the length of where the direction we go. So when you are that fourth intercostal space, you point it at angle 45. That is what we usually do here, 45 towards the apex, in order to get a very good arrow waves. So we use both Medtronic, that is a review, and also we have done one or two St. Jude, but it's mainly Medtronic that we try to use here. So this is, we do almost all the cases in the office. We don't go to the cath lab to implant a loop recorder. So the key issue about a loop recorder in the developing countries or in the sub-Saharan Africa is that I will say that don't wait for a home care monitor before you should implant it if you have a patient that needed it. Then two is that when you prepare your patient, always the key thing is that you should have your programmer, either Medtronic or St. Jude, depending on the device that you have there. I don't think we have any experience with Biotronic this way. what we have implanted so far is Medtronic and St. Jude. So then the other one, which is the most important, is that you must adequately prepare that skin. If you don't adequately prepare the skin, the patient will get infected. So the number 1, number 2, number 3 precaution is that skin preparation. So if you get that skin preparation right, you have a good day to go with. Then, as Dr. Chris said, is under the, you push it under the subcute. Once you get adequate anesthesia along the part where you will push the trocar, then the patient just relax. It's less than 5 minutes. You just take that punch on that skin because the anesthesia has already raised the skin for you. So you just take a punch on that skin, then you push it along, you turn it, then you push it in, then remove it, then you close, then that is the end. So for example, for this patient, we notice, see when the patient has symptoms, immediately we implant, then we close, then we give them that marker that when there is a symptom, go with that marker and which demonstrate it to them how to use the marker. So they take the marker on it and you get the marker on the distance. So this patient, immediately the patient had a symptom, he make a call. Then ordinarily on a free day, you also call them, is there any problem? Because I have all their numbers. Any problem, any issue, if they say no, fine. But you also remind them persistently that if there is a problem, if there is any issue you notice, just make a call and come to the hospital. So this one came just a few days ago, and see what I interrogated it with Julius, see what we got here. Even at a point we got that it's we had a bradycardia of 3130, but these are the one I show here. This is 33 bradycardia here, and when we look at it, it was Moby type 1. That was what we're picking up here. Then the other issue, yeah, this one we are taking some when I was doing analysis with Julius. So this one also another patient. So we usually follow the same look. This is after the recording. So we put a betadine gel, betadine ointment. I know you may not be doing that in UK. We put, after we close bar, we just put a betadine ointment, then put a plaster, leave it for like 5 days. They come, we take it out, then another 5 days come, we take it out, the place is healed, and they go home. So what we usually do here to overcome remote monitoring is that we persistently remind them, put sound it in their ear. If there is any issue, please come straight to the hospital. Then we also make call to them to remind them whether there are any issue. Then I want to get clear from Dr. Chris. One of the things that we found out here is that if there are recordings, assuming you have a recording 5 days ago, 4 days ago, 2 days ago, 3 days ago, and today, you notice that some of the recording in the past, which you have not seen, when they come, you don't see those recording anymore. That is one thing that we see among them here. So that is one of the key things that make me to also keep reminding them that if there is a symptom, come that very particular day so that we'll be able to see it. Because if that patient has a symptom maybe 6 days ago and is coming after 6 days of the symptom, more recording must have already been done, and you may not see what that loop recorder show during that symptom. I wanted Chris to comment on this issue that I brought up, because if you are using a remote monitor, you will pick it up when that symptom is occurring. But because we don't do that, we don't use remote monitor here. We depend solely on the programmer. So it makes us to lose some track. If the patient did not come immediately, when you need them to be checked, when they are complaining of symptoms. So over to you, Dr. Chris. So this is just our little experience this way, sir. Thank you very much.
Yeah, so I think patient education is really important in this. The device will only store the last few automatic recordings, and stores the last, for the Medtronic device, stores the last 3 symptom recordings, and it'll overwrite the oldest episodes. It has a limited amount of memory in it, so, and it doesn't have a preferential method for saving episodes.
Yes.
So it is very important to get patient education. Make sure they're not button happy. You know, make sure that they're only making recordings for the true symptom episodes, and they're not making recordings for a bit of chest pain, feeling a little bit breathless, or, you know, we're only interested in syncope, blackouts, or near syncope. I think make sure they don't mess it up too much. It's very important.
You are right. So AJ, for the St. Jude, how many recording before it wipes out the previous one for the St. Jude?
Yeah, so the current model, there's actually a newer model coming out here in a bit, but for the current Confirm and Jot models, it's 60 minutes of total time. So it depends on what kind of triggers you put in place. So you can actually define how long a recording should be, how long pre-event it should record. And the reason why you want that pre-event is just to have an idea of how like a syncope episode might have started. So bradycardia, like you can see what occurred before the bradycardia, before the AFib, what have you, and then how long post as well. So to your point, I would say one of the best things to do is customize the recordings to the patient. So if you're not looking for atrial fibrillation, turn that off, especially with the old Confirm before SharpSense 2.0, ton of false positives for AFib, which we don't need. So just turn off that AFib EGM recording. I'm sure the Medtronic has something along those lines too. So you really want to so you want to customize the programming to the patient. If we know that they're having bradycardia, most likely, we're not looking for tachy, then we can maybe turn that off if we think they're going to have a lot of false positives due to the device bouncing in the pocket. There's noise. It's just, you don't necessarily want to turn it off, but the later episode or the later devices across the board, I know that Medtronic does. I know that the new Jot and the other ones do are having preferential recording. So they'll record like the longest episode of an AFib, and then, but for example, for pause, it'll record like first, most recent, and then like the shortest pause. And the reason being because if it's a 10-minute pause, it probably wasn't real because the patient's still alive. So there's all these ways you can kind of customize it to this patient, and they're slowly adapting, but really it's just got to be customize it and make sure you follow up with them, or you're going to overwrite it and you're going to have to figure out what happened.
Okay. Then, Chris, how do you set up? Because immediately we plant, that does not mean that the recording has started. You have to activate the device before the recording will start. So in your center, sir, how do you go about in activating everything?
So I program it at implant. So as soon as we've implanted the device, the first thing I do is switch the device on, set it up, and customize it. Again, actually, customization is really important. Setting up, make sure that you've got an appropriate heart rate limits. So I've gone away from 3-second pauses because actually we get a lot of them through in the home monitoring, and almost all of them are not important. Okay. We are only interested in 4.5 seconds and above. And most patients won't have syncope until you get at least 6 seconds of an asystolic event. And that comes from one of the big review studies suggested that pauses of 3 seconds are pointless. They're almost irrelevant. The other thing is make sure you've got appropriate heart rate limits. The automatic setup for the Medtronic device, certainly for younger patients, puts the heart rate limits up at like 207 beats a minute. I still drag them down to 180, somewhere between 160 and 180, depending on the patient and their exercise level. And for the for the bradycardia limit, I'm only interested in significant bradycardia. So 30 beats a minute is your bradycardia below 30 beats a minute, or a pause of greater than 4.5 seconds. I'm not really that interested in anything else. These things are very unlikely to cause you syncope to have a heart rate of above 30. And if you have symptoms, well, that's much more important. So symptom and rhythm correlation is much more important. So if they have symptoms of with bradycardia of 32 beats a minute, at least if they've made a recording, that's useful.
Okay, thank you, sir.
That's great. Sorry to jump in. Dr. Syncope had a
Dr.
question
Syncope
about,
asked a question.
yeah, about prophylactic antibiotic after insertion or reserved for selected at-risk patients. So any kind of antibiotics, kind of like what you do with a pacemaker.
I've never given antibiotics for a loop recorder implant.
Okay.
I've implanted.
Correct. We don't also give, what we focus on is that skin preparation.
Yeah.
Your skin preparation has to be extremely good and stick to the sterile technique, especially in the sub-Saharan Africa. I keep warning it in the sub-Saharan Africa that, you know, the environment, some people coming may not be as clean as possible. If there is hair on the chest, ensure that you shave that hair off.
Yeah.
And they should take their bath very well and apply the adequate measures of sterile techniques to prepare that skin. You don't need an antibiotic.
Yeah. So I've seen one infection and it was related to the patient picking at their wound in that 1,000 patients. So we don't see infection very often, but we do use chlorhexidine to clean the skin, and we treat it like a sterile procedure. So hat and mask, gown and gloves, you know, make sure that we treat it like a properly sterile procedure. And we take it quite seriously, and some people think we take it excessively seriously, but infection is an expensive business and, you know, very unnecessary.
Oh, I was going to ask Dr. Edafe, but it looks like he's on the phone. The mention of lidocaine, do you have a recommendation what you standardly use for a lidocaine? One thing that I would recommend is you want to lidocaine the tract, not just the site of insertion, because they feel it as you dissect down. So
You're muted.
Yeah. So what I usually do, Chris, I don't know of your protocol in the UK, but what I do here is that I track the 2% lidocaine along the track of the trunca, so that the patient don't have pain, and I give it under the subcute, and to ensure that it's under the subcute, the skin along that track is raised up when you inject that 2% lidocaine. Sometimes I use 2% lidocaine with.
oh, we might have lost him for a second.
I think he's probably talking about 2% lidocaine with a bit of adrenaline in it, so xylocaine.
Plain lidocaine and a 2% lidocaine with adrenaline, anyone that is available for me. The reason why the adrenaline is that for patients who are on anticoagulation, I don't stop the anticoagulation. It's a minor prick along that part. You are not forming any pocket in any form. So I just give the 2% lidocaine with adrenaline, especially those that are on anticoagulation. Reason being that I don't want to expect any form of bleed when there is a punch on that skin. That is all.
Yeah, so I use the xylocaine on occasion, you know, with adrenaline, lidocaine with adrenaline, very rarely, but only on patients that are problematic with bleeding. I'll use 2 mils, you know, 1 mil at either side of the wound just to stop the bleeding. I use 2% lidocaine along 2 mils probably at the insertion site, and then the remainder along the tract. I use about 10 mils usually. I think, yeah, you just don't want it to be a painful procedure for the patient, and it doesn't.
As far as needle, I assume do you use a longer needle from the access site that you're going in, or do you use a?
I just use a long needle from the access site, and
Yeah.
also bend the needle so that you can inject.
Yeah.
Yeah.
So you can
Fantastic.
keep the injection very subcutaneous, because it's only that surface part of the skin that's really going to feel anything. Deeper down, you don't feel so much. The same as, once you're into the fat, you don't have that much to. But you're not aiming to be in the fat.
Perfect. Any other questions from the group? I know we had some questions in the chat. Everyone get their inquiries answered. All right. Well, if no one has anything else, we can jump into this quiz question. Dr. Llewellyn, I really appreciate it. Same thing, Dr. Edafe. I appreciate the presentation. It was great to see you hands-on there. So thank you both very much for your work today.
Thank you, sir. Great work. Thank you very much, Dr. Chris. Thank you, AJ. Thank you, Gilos.
Thank you, everybody. So
Yeah.
before we go, I'm going to jump into here. Can everyone see my screen?
Good.
Okay, perfect. Okay. So we had our quiz here, and Dr. Llewellyn, just to give you some details, we try to do like a quiz or something just to
The answer is showing.
I'm sorry.
Go ahead.
Okay, sounds good. Okay, so the first question, what do we suspect? Sorry, I just showed everybody, but what do we suspect happened during this high ventricular rate episode? What do you think we're seeing here? So this is an Abbott device. Because these are A and refractory and not just a tick mark, these are going to be a pacemaker, not a defibrillator. If this was a defibrillator and it was an atrial event and refractory on this marker channel, this would just be the tick mark without the AR. Just for your knowledge, this is your atrial channel. This is your ventricular channel. Anybody want to take a shot at it, even though I just showed you the answer a second ago? I don't know if Elvis made this call. Elvis, you on the call? Somebody in the chat. We got 100. Okay. Perfect. Well, I'll go ahead jump in then. So this is a VT.
Okay.
Oh, there we go. Elvis.
We got it.
Yeah. So
You showed it already.
yeah, I showed it. But he got it. I trust that he didn't see it. And he actually
Good work.
got it. So yeah, this one's a pretty simple one, just to say VT right away, just because you do have more V's than A's. So if you look at the atrial channel, you have more ventricular events. That is an indicator that the ventricle is actually leading. You do see 1-to-1 here later. And then I will send this out with the full description of what's going on. He does a really good job of explaining what we're actually seeing here, and how you can measure, for example, this V to V timing here and compare it to the V to A timing and see that it's the same. But then if you track it forward, it doesn't link up with the A. So this indicates that if we did not see this half of the screen, that your ventricular event is actually driving your atrial event in retrograde. So this is VA retrograde conduction. And yeah, that's pretty straightforward. Does anybody have any questions on what they're seeing or what's going on at all? I'll scroll down so you can see this, and I'll send this out to the WhatsApp group as well, so everyone can see the answers.
Can I put one comment that one of the things that's quite important to look at, if you go back up to the EGM, is actually when you first interrogate the patient, if they're in sinus rhythm, take a strip of the EGM and look for the change in morphology of the intracardiac EGM. That's probably quite important as well. So look at currently and the event.
That's a really good point. And one thing I'd like to say about this is that if you see here, these are both sense amps, I would say, judging by the morphology, which are very hard for a human being to discriminate. Sense amp and even bipolar to a lesser extent, but still, it's hard to see morphology changes as much as a far field channel. So I always recommend having a far field trigger saved for your EGM channels. So make sure that it has a unipolar tip or LV tip to CAN or something like that, so you can see what's happening across the whole heart, so you can have a decent idea of morphology and discriminate between conduction and ventricular initiated events like PVCs or VT. So thank you, Dr. Llewellyn. That's a good point. All right, Next question. I'm going to try not to spoil this one. What is happening here? All right. So we had somebody who was ready to chime in. I'm not sure if that was you, Elvis, but what's going on in this EGM? Anyone? Feeling lucky? I won't judge you. If you get it wrong, it's okay.
Ventricular pacemaker.
Somebody's child is chiming in on that.
Sorry, that's me, AJ.
Oh, hey, Jared.
There you go, man.
I think someone said ventricular based, but I wasn't sure exactly what they said.
I was thinking whether this is a PMT, perhaps.
Dead on. Yeah, it is PMT. So pacemaker mediated tachycardia. Yeah. So I guess like let's just break it down. So what's happening? PMT, what initiated the episode? If someone wants to jump in, or Jared, you can take it, whoever feels like it.
Yeah, sure. So obviously we got, if we go right to the left of the screen, we've got an A paced followed by a V sense. So we've got a normal, even further to the left of that one, yeah. And then we've got an extra V sense that happens, which is likely going to be a ventricular ectopic. And then we've got another A paced. And that says, that looks like it's sensor indicated rate. And that's timed out our AV delay until we get a V pace. And then it looks like from there, we probably get a bit of VA conduction occurring at that point, which then sets up your PMT.
Yep, that is exactly correct. So as you pointed out, when we were talking about making sure you have a far field, I don't like the leadless channel personally, but it is technically a far field channel. And you can see morphologically, it's different from this ventricular sensitive event to this one. So this is a PVC, I would say. These look different, obviously, because they're paced events, and they kind of actually look more like a PVC than the intrinsic, which is pretty standard. So you have a conducted event, you have a PVC. If you look here in the atrial channel, you have what is most likely a retrograde atrial event, and you can actually see it on the leadless channel. So that means that when we pace in the atrium, you don't see an evoked response. And the reason we don't is because the atrium was probably, it's a functional non-capture, basically. It was not ready to receive the atrial pace, so it doesn't do anything at all. The device thinks that the atrial pace probably captured. It didn't see this atrial event because it falls within this solid black line here on the top, which is your, I'm not sure if you can see my cursor, hopefully you can, which is your atrial blanking. We atrially pace, doesn't capture, we ventricular pace, and since the atrium is now ready to receive a retrograde event or any kind of atrial event, the retrograde runs backwards, the device senses it, it then V paces again, runs backwards, senses it, V paces. So this is that pacemaker mediated tachycardia where the device acts as the conduction pathway. So it basically completes the circuit to create a nonstop endless loop tachycardia. So what terminated the episode? Anyone? Julius, you still in the chat? You ready for it?
Yeah. I've still got a number here. So I don't think there was a PVAP extension. I think it's because it would say it there. It would say it there. But you've got 8 piece. Yeah, sorry.
Oh, no, you're sorry. Just see the Abbott device will not say that.
We'll say that.
So,
okay, it must have been a PVAP extension then. Yeah.
Yep, exactly. So what it will do, it's kind of essentially like a PVARP. What it does is it when it detects the PMT, it does a little wiggle test, which you can see here. It changes the V to V timing, and then when it sees the V to A timing doesn't change, the device then basically will withhold the next V pace. So there would normally be a V pace right here, but it holds it back. It waits 330 milliseconds after the last atrial event, which gives the atrium time to basically be available to accept a pace. It then paces, so 330 milliseconds, 328 is technically what it says, but we'll call it 330. It atrially paces. We now have control of the atrium, and you can see that with a capture. and then we V-pace here. So absolutely right, Julius. It's the pacemaker-mediated tachycardia intervention, basically, which is essentially like a plus PVARP. All right. So we now see, okay, this patient's been having PMT. It's a good time to go ahead and ask them, hey, have you felt palpitations in the past? And a lot of these times they'll say, yeah, it feels like my heart's pounding frequently. So then you can say, okay, well, we need to do something. What test should we perform? Anyone?
So do a retrograde test, and then work out the VA interval, conduction interval, and then adjust your PVAP accordingly.
Perfect. And do you mind just telling the group how you would do a retrograde? Not that I know you know this, but
so do VV, put it both in VVI, and then do pacing up from 80, 90, and then watch the VA interval, and then obviously work out on the atrial EJM, work out the VA interval, conduction interval from that, and then use that to work out your PVAP.
Yep, that's exactly it. So, and yeah, I think you answered the last question here too, is it's PVARP, right? So to do a VA conduction test, you can either do permanent programming or do temporary programming, depending on the device and its capabilities. As Julia said, you want to pace at different rates, just because patients may not have retrograde at 100 because they're going into like an effective block, but they may have retrograde at 80. One of the things that you'll see common with PMT is it will go at the max track rate. So if the max track is 120, you may see it occur at 120. However, the PMT rate is actually a function of the total retrograde timing plus your AV delay, your sensed AV delay. So your PMT timing is going to be your retrograde here plus your A to V timing, your AV delay. So if you have very long sensed AV delays and very long retrograde, your PMT could be much slower than 120 beats a minute. It could be 90. So in these instances, you may see patients that have otherwise good conduction, but a higher than normal ventricular pace burden. Sorry, my watch. That indicates that there is they may be having PMT, and it's something worth looking at. So you do your retrograde test, you VVI pace, you watch the atrial channel to see that retrograde occur. Keep in mind, if their own atrium is going faster than your VVI pacing, you're not going to be able to see it. You have to go fast enough to overdrive. So if their atrium is going 80, you need to at least do VVI 90. I'll do usually 90, 100, maybe 110, but usually 90 to 100 is about as fast as I'll go. I'll measure the retrograde timing and see how long it takes to get from the ventricular pace to the atrial sense. And then from then, you'll set your PVARP timing to cover that up. Just keep in mind that a lot of these devices have a shortest PVARP. So that's when you're using rate responsive PVARP. Your standard PVARP may be 225, but your shortest PVARP may be 175. So you could be extending your normal PVARP up to 300 all day long, but if your shortest PVARP is still too slow, you're not going to properly cover this retrograde atrial event, and you're going to track it. So just make sure you extend your shortest PVARP as well. And looks like y'all got the answers here. I don't think there's any more. Okay. So that's the answer. And like I said, I will post this, but if you want to pause this on YouTube later, this is the explanation.
Yeah, AJ.
Right. Yes, sir.
Somebody asked what caused the pacemaker mediated tachycardia. Did you answer?
Yes, it was
Yeah,
answered before.
that was before.
Okay, maybe just recap it again.
Oh, yeah. Yeah, I can recap.
There was a retrograde conduction.
Okay. Because Dr. Seko asked the question. Maybe I was not around when you were answering it. Sorry.
Oh, no worries. Yeah, so there's two answers to that question. What caused this specific instance is the PVC, and sometimes you'll see a PVC initiate it right away. In this case, it's actually functional non-capture due to a PVC having a retrograde A, pacing the A and not capturing, the atrium being ready to accept a retrograde in this case. But what causes PMT in general is retrograde conduction and improperly programmed PVARP. So that's the real answer. Like, why do they have PMT? Our PVARP's too short is the function of it. Sir.
Yeah.
You don't always want to set your PVARP super long, by the way, if they don't have retrograde, because that can also affect your ability to track real atrial events. So if they don't have retrograde, don't just kick the PVARP up to 300 because you're going to lose your function. It's going to affect your 2-to-1 block rate with the device because your total atrial refractory period, or TARP, will be too long. Okay, so last question. What is going on here? Ignore all the arrows. Well, I mean, I guess they're kind of helpful. Anyone want to take a shot at what the device is seeing, what's occurring, what the VS2 means?
I could come in and this one if you want.
It seems to be sensing. Seems to be oversensing. The V sensing will oversensing.
Mm-hmm.
Likely sensing an atrial rhythm, atrial beat as a ventricular beat.
Correct. Yep, that is right. Bonus question. What is this? Do you know? This is Abbott specific. So if you don't know, don't worry about it.
Is that your secure sense?
Yep, exactly. So this is the Secure Sense. Basically, what Secure Sense does is anytime there is an event that is like a non-sustained RV oversensing or any kind of triggered event, the device is always checking to see if what's matching on the far field discriminator channel is also matching on the near field sensamp channel. So in this case, the device says, far field, I see this event. This event was oversensed by the device. You can see it here, but we don't see it on the far field here. If it did, you'd have another VS2 right here as well. So this is on the far field, not visible. So the device flags it and says, hey, you may want to take a look at this because we're oversensing events. So that you're exactly right. That's a Secure Sense intervention. Just to go over this, this is a custom coil to can vector. Discriminator is also going to be like a far field coil to can as well. Here you have your little X's. This indicates morphology template match. As you can see, none of these really match the morphology template except for this guy here, but some of these are kind of close. So 88, 87, the template's at 90. So they're right there on the cusp, but these like PVC events here and here don't even match at all. So all these little blue arrows are PVCs. You can see here on the far field channel, there is a larger atrial event occurring. We can't even see it on the SynSamp channel, one, because whoever did this red arrow covered it up. But even if we could, if you see our gain is so small that we wouldn't be able to see it. So it's a function of very low amplitude RV events, allowing the device to get so sensitive so quickly that it's able to oversense the P waves. So in these cases, you can try to blank it out by raising the sensitivity a little bit. There's a number of things you could do. So here's the full description. Any questions or comments, anything like that? Nope. Okay, perfect. Well, if no one has any more questions, I will post this all on YouTube later on this evening, so the group will be able to watch it. But I really appreciate everybody's time. Thank you very much, Dr. Llewellyn, and thank you, Dr. Edafe, for
Thank you
jumping on,
very
and
much,
everyone for your
Dr. Chris.
questions.
Yeah.
He's still
Thank
muted,
you,
but
AJ.
It was a pleasure to talk to you.
Yes, sir.
Thanks,
appreciate
Chris.
it.
Thanks, AJ.
Thanks, Julius.
Thanks,
Jared.
Julius.
Thanks, everybody.
Thanks, guys.
Thank you very much.
Thanks, Jared.
Thank you, Dr. Seko. Thank you, thank you, thank you.